All right, everybody. So, welcome back to our week one lecture for the outpatient billing and reimbursement course. We are now into chapter number 2, which is an introduction to health insurance and managed care. As usual, we will begin with our objectives. And so there are 8 of them. One, for you to be provided with an introduction to health insurance, and it's a beast. Summarize the basic health insurance and managed care concepts. We're going to look at the major developments in health insurance, which really dates back to like 18 something. We are also going to look at managed care from the perspective of history, role, and effects. We're going to look at the characteristics of health insurance and managed care, consumer directed health plans. Documentation is key for insurance, and then the impact that the electronic health record has had on healthcare. Okay, so remember how I told you that you should make flashcards for each chapter? I did not count them, but chapter 2 has so many terms. And one thing I will just call out that may be an option for you is Quizlet. And Quizlet, you can have your cards electronic, but also you may find that someone else made cards for these chapters and you can use them electronically. One thing I will question you about related to Quizlet is to make sure that you double check what is on the Quizlet file because there have been some errors. All right, so the outline for the chapter mirrors the objectives. So let's dig in. So, in the very beginning of this chapter, they want to give you a foundation where you understand what is insurance. And I think of health insurance, car insurance, and other types of insurance where basically you need it, but you don't use it. Let me rethink that. So you need it, but you don't use it until you need it. And so that's one of the things that I think a lot of people hate is because you pay a lot of money for something that you may or may not use. Now, clearly in healthcare, at some point in your life, you're going to need health services, right? But I think one of the things that is very controversial today is the cost. So, insurance basically is protecting you from loss. Um, the insurance company guarantees payment, not 100% payment. And it's not 100% because we operate in a system where everything is discounted. For insurance plans, in order to get the plan started, you have to pay a premium. And that premium is typically paid monthly. So if you think about car insurance, it's paid monthly. And outside of health insurance, there's all types of insurance. I talked about uh, car insurance, but there's so much more types of insurance. And then as it relates to managed care, it's really about managing the patient's care by the least amount possible. And the goal is to keep the patients well and not sick. So here are, oh my gosh, and again, I'm not going to go through each and every aspect. And you probably are wondering, do I need to know all of these aspects? So, one of the things I will tell you is this summer, you will, in addition to your practicum, you'll be preparing for whatever exam you're going to take, CCS or CCSP. And so, I would say you need to have a basic understanding of insurance. And then, when it comes time for you to study for the exam, in your review guide, you'll kind of see what areas you really want to dig into. So, no way I can get into all of this in this little 30-minute lecture. Believe it or not, insurance is regulated by the states and not the government. Even though I feel like the government does have a hand in it. And what you're looking at is a list of responsibilities. And I haven't heard this term in a while, and primarily because I'm not working in the insurance space. But sometimes people will go to the state regulators to have something enforced that an insurance company is not necessarily doing properly. All right, so some statistics, and this is from 2021. This book is updated every year. And so they try to keep the statistics current. But what you're seeing here is that 70% of the population in 2021, close to 70%, had private health insurance. Now, I wonder in 2025 what that looks like. And I say that primarily because of the aging population. The baby boomers are starting to retire or have retired. And so, I think the Medicare number is probably a little higher. Now, what's really interesting is the comparison of Medicare versus Medicaid. And in this course, we will pick apart both of those plans, but very simply, Medicare is for individuals that are 65 years or older, end stage renal disease, whereas Medicaid is for individuals that are medically needy or categorically needy, which again, we'll get into. But if you look at them, if you just say, round it up, that's like 40%, right? A little less than 40%. So that's a large chunk of the population that are either, Medicare age or they are low income or some type of disability. So there are some terms you should be familiar with, and I think that this is one of those things that you want to be familiar with. So a group plan is basically it means you belong to a group, whether it is through employment or sometimes other organizations such as unions have insurance that you can purchase as a part of the group. And basically, what happens is the cost of that coverage is distributed among the members of that group or that organization. So, as you think about your future state in terms of having employment, one of your benefits is going to be health insurance. How much you pay for that really depends on a variety of factors, how large your company is, because the company pays a portion, you pay a portion. And so there are a lot of factors that come into play. Then individual health insurance, and this is when you don't have access to group health insurance. So maybe I'll use my example, self employed, right? And so you go to an insurance broker. Remember, we talked about independent contractor, right? So you go to an insurance broker who in turn assists you with getting private health insurance. Public, we talked about Medicare and Medicaid, but there are also other public plans such as CHIP, And then that's the Children's Health Insurance Plan, and then TRICARE, which is for our active duty military professionals. All right, so major developments in healthcare. So, at first glance, when you look at this diagram, you're like, whoa. Well, luckily, in the textbook, there's actually a very long table, in addition to this diagram being in there. But if you look in the middle of the circle where this history begins, in 1850 is when we had the first health insurance policy. But then if you look at every little orange circle, you will say, "Whoa, it's just like back to back to back." There's something new, which is why people say that healthcare in the US is extremely complex. For purposes of the CCS exam and the CCSP, because I know you're wondering, what do I really need to look at? So again, definitely when you get your review guide this summer, you're going to see the types of questions that they ask you. But what you do definitely need to know about are the reimbursement methodologies. And if memory serves me, we will cover that somewhere around chapter 4. But you also learned about them in the inpatient billing, the different reimbursement methodologies. Remember, prospective payment system, MSDRG, APCs, and the like. All right, so the Affordable Care Act. One of the things that the Affordable Care Act did was establish the PPACA, which is Patient Protection and Affordable Care Act. It also established this Healthcare and Education Reconciliation Act, which again is going to be covered in more detail in the chapter. I'm trying to be very high level and make it through 30 minutes. But I did want to highlight the risk adjustment program, the model, and what's known as the transfer formula. So let's look at this example. So you got a patient um, who is 57 years old, okay? And an average risk score is 1.0. And the formula, so like what's the risk of that patient, that member? The formula for calculating the total risk is the demographic risk factor plus the health status factor. So when you think about um, this big push towards healthy eating, decreasing the obesity rates, you see the increased use of things like Ozempic and weight loss surgeries. People are trying to reduce their health status. So, 57-year-old demographic risk factor zero point 0.5, and then health risk factor zero point 0.7. Now, remember, average is 1.0. This patient has a risk score of 1.2, resulting in the plan receiving higher payments because why? The risk is greater than average. And so this provides an incentive to a health plan to enroll patients that are higher. But this is what I know. When you have a patient who has more conditions, they are going to utilize healthcare services more. And so in the end, we may be um, getting less than what we are spending in terms of the care that's needed for that patient. So the PPACA, which is also known as Obamacare, was not designed to replace health plans, but really to allow Americans to purchase coverage that fits in their budget. Now, if you talk to someone who is on Obamacare, they will tell you, or ACA, they will tell you that Yes, it gave me access to the in, to health insurance. However, it was not necessarily cheap. So that was kind of one of the complaints of the system. And basically, what you had is those, insurance plans trying to fight for these patients. And we'll get into healthcare costs because a lot of times, to a non-healthcare professional, healthcare or healthcare organizations are getting paid lots of money. But here's the reality: what we charge and what we get paid is vastly different. And then you must also consider the fact that the healthcare organization has to pay bills, and the largest expense is salary and benefits. And so after salary and benefits, then you got the supplies and the cost of doing business. And I can tell you, as a business owner, it's just like your personal budget. You're bringing you're spending more than you're bringing in, which means you are operating at a deficit. And so when you see this trend where um, health systems are buying smaller hospitals, um, doctors' offices becoming under the umbrella of a health system. And it's just the cost of doing business is high. I mean, think about utilities and all of that. And think about that in your space versus a big gigantic building. All right, so managed care. And while I'm thinking about it, if you want to see a good movie on managed care, check out Damaged Care. I remember when classes were on campus, I used to show that movie in class. But that movie details the life of Dr. Linda Pino, who was a physician who started working for the insurance company. And that's all I'm going to say. All right, so managed care is about controlling costs. It's about decreasing utilization of services and providing quality care, all within a contained structure. And this is made possible through contracts, right, that are established between individuals or healthcare programs and the MCOs. With managed care, one topic or term that you definitely want to be familiar with is the term capitation. And basically, I want you to get this: capitation means that, and let's just use a doctor who contracts with a particular insurance company. The doctor is going to receive a set dollar amount per member per month. So, just for ease of math, I'm not a math person, but let's say this one doctor receives $10 a month, right? For each patient. Each patient that signs up with that provider being their primary care physician. So that means in 12 months, that's $120, right? 10 times 12, 120. So then they don't get additional monies for that, right? So when the patient comes to the doctor's office, that's eating away at the money. So I want to give you an example. I recently went to a dermatologist for hair loss, and I recently got my bill electronically, and basically my bill was the charge was $250. And so my payment is $124.77. And so I'm not in a managed care program. So every time I see the doctors that I see, they get paid, a certain dollar amount. It's not what they charge. It's discounted. And we'll talk about fee for service shortly. So think about the situation where the doctor is getting 120 per year per patient, and what you're going to find is that works well if the patient never comes to the doctor's office, right? But if that patient is constantly coming to the office, that's eating away at the money. All right, so let's see. Managed care organizations and plans. I talked about capitation. There are also some other variations of the capitation program, which honestly I'm not well versed in because I don't work for the insurance company. And I, as a consultant, don't necessarily get involved with insurances because that's not um, the focus of my day to day work. All right, so managed care models. There are someone here that I'm sure you're familiar with, the HMA. Don't forget, watch Damaged Care, great movie. Um, but then there are other models, exclusive provider organization, PPO. I have a PPO, point of service plan. And honestly, what happens is with these models, right? You pay the cost to be the boss, right? And what I mean by that is a PPO, we're going to pay more per month. We're going to have a percentage of what the insurance company pays. But in exchange, we don't have to go through a referral to see a specialist. I literally can, like I did, I made a decision that I have some hair loss. Right just past where my natural hairline is, right? And so I made a decision in conjunction with my hairstylist that I needed to see a dermatologist to kind of figure out where this hair loss is coming from, right? So I just called, make an appointment, and I was in. All right. So the effects of managed care on a physician's practice is that they have to have some bookkeeping systems in place for each capitated plan. One may give $10 a month, one may do $8 a month, right? It depends on what they negotiate. But then the other thing that has to be taken into consideration is the pre-authorization and pre-certification process. In that movie Damaged Care, you'll actually see you'll see that in action. And so basically, we have to have systems in place to actually get the pre-authorization, pre-certification, which basically is, before the service is provided, we have to call the insurance company to gather some information and or approval, authorization, pre-certification for that service. So one perfect example is a patient is going to have surgery. We need to contact the insurance company to find out if they're going to pay for that service. And then after that, to what extent, right? How much do they pay? How much is the patient responsible for? And some organizations have made a decision that, okay, we find out the patient is responsible for 20% of this bill. We're going to ask them for that money up front because think about it. Before you have surgery, you're very vulnerable. You're like, okay, let me just pay it if you have it, right? To get it over with. It's a lot harder to collect the money on the back end. And so that's why they try that approach. I had surgery probably 10 years ago, and my portion, I think, was like 1,400. And so they asked me for that money up front. And I was like, I don't have $1,400. So what I did was I paid a little bit leading up to surgery, and then I paid some more on the day of surgery, and then I paid the rest afterwards. But the thing is, and chapter 4, I believe, talks about revenue cycle. Healthcare, we have to bring money in, and I want to make it personal to you in order for you to get paid. If we don't bring money in, how do we get paid? All right. So, with this pre-authorization, pre-certification, another thing that to consider is when a patient wants to or needs to see a specialist, the primary care physician has to approve and do a referral for that service. Um, Also with managed care, you have co-payments. That's a small fixed amount that's paid at the time of service. Many organizations have seen the value of collecting that money up front as opposed to trying to bill you, right? Because when we bill you, we got to use an envelope and a letter and ink and time to prepare a statement for $20. We can just collect the $20 up front. All right. Other characteristics. I remember I talked about um, that we get paid on a discount. So fee for service is a term that means you charge a fee, you get paid for that service. Well, today we are operating on a discounted fee for service. Like we may charge $250, but in our contracting process, we agree that we'll accept 125 for that service. Then we have value based reimbursement methodology, which is really about quality, right? So the provider is compensated if patients are well as opposed to sick. Then you have some third party payers who are involved in managed care. And the characteristics of health plans and managed care are similar because they operate with the structure of the patient having a primary care provider, yeah, and then the office coordinating how the services are utilized. All right, so a primary care provider is also known as the gatekeeper, and with these plans, providers are incentivized to keep you inside the gate, meaning before they send you to a specialist, let's try to resolve the problem, right? And then we resolve the problem, and then you don't need to go and see the specialist. Well, if you do, um, that does impact the money from the primary care physician. But for that service, the patient needs a referral. And if you have an HMO plan and the patient goes to the specialist without that referral, um, that service may not be paid for because it's not like, let's see, what's something my husband says uh, ask for forgiveness instead of approval. That doesn't work in this setting. If a service needs to be approved, pre certified, pre authorized in advance, that has to happen. It's not optional. All right, quality assurance and performance measurement. So, quality assurance, QA or QM, is really about looking at if quality care is being provided in a healthcare setting. And it also looks at what patients are saying about the care that was received. Performance measurement is really about looking at if evidence based treatment guidelines are followed. And in the book, they have a little bit more about evidence based, and you probably saw it in your introduction to health information technology course, because that is a topic that is pretty common there. All right. And then oversight is provided by lots of external organizations, and some of them are called QIOs or quality improvement organizations, as well as the National Center for Quality and the Joint Commission. So NCQA, they are really looking at the quality of managed care plans and they release that data to the public. They give a report card. And that report card allows us, if we can, make a decision about, I don't want that plan because they're known for doing XYZ. NCQA also developed HEDIS. HEDIS measures, you'll hear about that. And it's another way to evaluate managed care. All right, quality improvement, also known as QI, is really looking at like what resources are needed to improve the quality of care for a population of patients. And as part of this, we have what are known as clinical practice guidelines, which basically defines for a diagnosis what is needed to treat the patient. So the modality for a diagnosis. Utilization management, also known as UR, this is a way to control costs. One example is, let's say a patient is in the ER and the ER doctor is thinking about admitting the patient to the hospital. Well, you are or UM would be responsible for getting pre admission certification for that hospital admission. And then while the patient is admitted on a daily basis, where they're continuing to evaluate if that patient meets the criteria to stay at the hospital or do they need to go home? And I like to say that the objective of admission is discharge. And so discharge planning literally starts when you get admitted. What do we got to do to get this patient home safely so that they can recover at home? And there is a URO organization, which is an agency that does external review for managed care services. Then we have case management. This is a term that's pretty common. Case manager is the one that authorizes patient treatment, and they basically coordinate services to improve patient outcomes. So, two terms on this slide that you want to be familiar with for the CCS exam and MSDRG is the concept of severity of illness and intensity of service, SI and IS criteria. Will be covered more in the course. Second surgical opinion. This is when a second provider is asked to basically confirm that the patient needs the surgery, right? That second person may say, well, no, let the patient could do physical. Let's do physical. You can do physical therapy and the patient could get better, right? But then also they're looking at what's the most economical facility. So outpatient surgery versus inpatient. Sometimes managed care provides an opportunity for a second opinion for certain things. Sometimes they may even seek a third opinion, right? So you got Dr. A, and then you get a second opinion by Dr. B, and then, well, let's see what Dr. C says, because maybe that person can break the tie and the patient really doesn't need surgery. All right, prescription management. This is basically controlling medication costs, and there's a couple of strategies, but I'll just use one as an example. I have a medication that I use for my asthma, and one day, all of a sudden, I don't know if I was sleeping or what, but that medication was all of a sudden $230 a month. And so I had to call my doctor's office and say, hey, I need something different because I can't pay $230 a month for for a medication. So, as part of this management process, they're negotiating prices. They're looking at generic versus brand names, and insurance companies have a what's known as a formulary, which basically shows what they will and will not cover. And sometimes the doctors don't figure this out until the patient, goes to the pharmacy to get the prescription, and then the pharmacy says, oh, well, that medication is not covered by your plan, and if you want it, you got to pay for it. Consumer directed health plans, CDHPs. This is where basically, as an employer or employee, your employer asks you to be more responsible for healthcare decisions and cost savings. And so um, the book calls it like a 401k for health plan. And so I think two that are probably very common to people are the flexible spending account and the HSA. And so with these, you are having money taken out of your check. I believe it's before taxes. And so I'll use an example. We have an HSA where the money comes out of my husband's account, or paycheck. And then when we have a copay or we have some other out of pocket expense, we use that card to cover the service. But depending on what type of year you're having, it you may run out of money. That's another story for another day. All right, healthcare documentation. The Joint Commission says that documentation should be legible, complete, and timely. The legible part, we really have not had to worry about as much because, we have this increase in electronic health records. So that's not something that is as much of a problem today as before. I will tell you that on top of the Joint Commission standards, which are um, also connected to the Medicare conditions of participation, HEMA has standards, the 7 principles of high quality documentation. And so combined with those two, the goal is to have a patient record that has what is needed so that when the patient goes from one provider to the next, that second provider gets the documentation. They don't have to repeat tests that maybe the patient just had. But also, they can see what happened and continue the care. It's known as continuity of care. Teaching hospitals. You probably have heard of teaching hospitals. We have several of them here in the United States. And that's when the medical residents are, some people say practicing on you, but they are receiving education with a teaching physician who is guiding their activities. So organizations that are teaching hospitals, they do receive money, GME, graduate medical education funding from the government. And this was actually covered in your last course. So what your inpatient course, one of the things that I will tell you that sometimes students do in programs, they pick and choose what they will study. And keep in mind, you never know where you have to pull some information out from your toolkit. And so, as part of the teaching facility rules, the resident is actually documenting in the medical record along with the teaching physician, and that teaching physician is basically attesting to the information that they agree with it or they agree with it, except right they may make changes to diagnoses and plan of care. Documentation is critical for coding and reimbursement. There's this statement that if it wasn't documented, it didn't happen. And one of the things you need to understand is that insurance companies, when we send the claim to them, they don't get the medical record. They only get the medical record if they ask for it afterwards. And afterwards, meaning after the claim has been submitted, but prior to them paying. And so one of the things that they're looking at is that the services were based on medical need, also known as medical necessity. So remember the concept of what happened today, CPT, why it happened, diagnoses. That is part of the process of establishing medical necessity. All right, types of medical records, which you learned about in the Introduction to Medical Records course, but we have a problem oriented medical record. And this type of medical record has 4 parts: the database, problem list, initial plan, and then progress notes. And this is covered in more detail in the book. Electronic health record. I think a lot of times people think EMR and EHR are different. So, EMR is like one single location. EHR is a record that could be seen by more than one location, right? And you can read more about that in the chart. Um, so EMR, I've already mentioned that's like for a single medical practice. So you go somewhere else, they can't see that information and has to request it. All right, total practice management software. This is basically the software that we're putting the information in when the patient arrives for registration. I remember back in the day when these systems were first established. The salesman would just sell you anything. And then when you realize, oh, well, this system doesn't talk to that system. And that actually still happens today where you have one system doesn't talk to the other. And so you have what is known as an interface to get the two to connect. If not, you got to just log in from one system to the next. All right, we're wrapping up here. Electronic clinical quality measures. This uses EHR data to measure quality. Are you noticing something? Quality, quality, quality. All right. So, lastly, the quality payment program, QPP, is really about focusing on the quality of patient care and the patients getting better instead of sicker. There is a whole website on QPP programs in case you're interested. All right, so we are back where we started, and we looked at health insurance, managed care, the development of the US healthcare system, managed care, the history, the role, and the effects. We looked at some consumer directed programs, like I mentioned, a 401k type of health system or health plan. So HSAs and FSAs. We also looked at the importance of documentation and the electronic health record. Well, this is all for week number one. Week number two, we're going to look at managed healthcare. So, yes, we'll talk about it some more. This chapter was just a very basic overview. And then next week, we also are going to look at revenue cycle management. See you next week.